Bueno, el caso se trata de un paciente masculino de 68 años de edad, con un índice de masa corporal de 23. Como antecedentes personales, el paciente es hipertenso, tabaquista, tuvo una ACV en el 2022 y una RTV en el 2023, con una anatomía patológica para un carcinoma papilar de bajo grado, sin músculo presente en la muestra. Consulta a nuestra institución por hematuria intermitente y la ecografía nos revela una lesión vegetante en el piso de la vejiga. El PSA control es de 0.48. Esta es la ecografía que muestra una lesión de 3 centímetros aproximadamente. Y la citoscopía muestra la masa en la cara lateral izquierda de la vejiga. La resonancia informa una lesión focal con crecimiento endobinal en la vejiga de aproximadamente 30 por 27 milímetros. Vemos el corte coronal. Y le reportan que respeta el estrato muscular, por lo que la clasifican como un BIRAT 1. El paciente tiene una función renal conservada, el urocultivo es negativo. Y damos paso a quirófano.
Norberto, ¿está todo listo ahí?
¿Me escuchan?
Sí.
¿Me escuchan?
Sí, sí, te escuchamos.
Bueno, bien, el caso fue presentado, creo que hasta tenían una imagen de una cistoscopía, ya vemos que cuando se ingresa, just to be clarified, our friends Bernard and Gaevlete and the people in speaking in English can be connected with the link with the translator. I will be speaking part of the time in Spanish, just to let them know that I'm speaking in Spanish, but you have simultaneous translation. Okay, we have a tumor that has in the MRI, en la resonancia tiene más de 3 centímetros, con lo cual está fuera del consenso inicial de las guías internacionales de resección en Bloc, que dan hasta 3 centímetros de resección y hasta lesiones que pudieran ser 4 en la vejiga siempre que tengan menos tamaño. La idea es hacer una resección en bloque. Nosotros estamos visualizando el meato ureteral derecho. A simple vista nos dirigimos hacia la zona tumoral y no estaríamos viendo con claridad todavía el meato ureteral izquierdo. Si vemos la cara medial del tumor, la parte exofítica superficial y la cara lateral, viendo que la vejiga en su cara lateral al menos no tiene base de implantación. Vamos a revisar ahora a ver cuán cerca del meato está. Nos estamos aproximando, voy a necesitar agua por favor, nos estamos aproximando a la base.
Norberto.
Yes.
It's Giorgio from
Yes.
Como in Italy.
Hi, Giorgio. Thank you for being connected.
Oh, that's fine. It's a pleasure. So, can you just tell us the settings you will use?
I'm sorry, Giorgio, I cannot hear because some kind of the connection. Could you wait a second because I cannot hear you? Give me a second, please.
El seteo del láser te está preguntando, me parece.
We will be using the Magneto, is the new device from Quanta Systems, and we will be starting with the coagulation with 1 joule and 10 hertz. I will be using left pedal, Giorgio, but before to start, I want to see clearly how big is the pedicle, because according with the MRI, it's not so big. However, I want to see a little the ureteral meatus. I see the base of the tumor.
So it seems to be that the pedicle is not that big as the neoplasm is.
right. You are totally right, which is good. And the first decision that we will take is, for sure, having more than 3 centimeters. At any time, I will have to cut in pieces because it's impossible to remove in block resection, even if I can remove it in block. But the idea is just to avoid to free totally. You see the meatus here, Giorgio. I don't know if it's clear, the image there. It's not so
Image
close,
is
but
very
close.
clear, and you're doing a fantastic job. So just keep on, and your suggestion to cut at the end the neoplasm is the best way. Otherwise, you cannot get it out.
Yeah, you're right. But
Norberto, hi,
the
this is
idea regarding
Bogdan.
this issue,
First of all, I'd like to thank you for the invitation. It's a real pleasure to be with you and with such great personalities today. This is this is a nice case. The tumor base, which is not so big in surface, is an advantage. But I'm a little worried about the tumor bulk being large. So I will be very curious to see how you manage to take it out in the end, because as you know, according to the Delphi consensus, to the European Urology publications, and to most of the literature, the 3 centimeters diameter is about the threshold to the maximum limit for block resection. Now, I have been doing this procedure for 15 years, ever since I introduced this as an international premiere in the European Urology Today. So I love the procedure, and I try to push boundaries myself in terms of size, location, and other technical challenges, vicinity to the ureteral orifice or to the bladder neck. But the thing is that the extraction of the tumor, personally, I find it sometimes challenging. And I would like to ask the other moderators, what is their view on this topic? How do they find this apparently small but potentially difficult technical feature?
Shall I give some words of comments? Okay. So first of all, many thanks for the invitation. No doubt that it is a landmark in the live surgery program across the year and around the world. Second, what I like very much in your presentation is that you took the pain to evaluate pre-operatively at the best of your abilities the extent, the volume, and the vicinity of the tumor, because doing a resection of a 3 centimeter diameter tumor is feasible on block, not a big issue. What is not, what should not be, what should be avoided actually, is not to know exactly in which kind of challenge you are embarking. And there you did the MRI, you saw that the bladder wall was thin enough. Therefore, you were not too worried about a deep extension, something that would be a T2 or more than that. So that was exactly in keeping with recommendations, the current recommendations in en bloc, pre-operative evaluation. Second, you are doing an expert endoscopy. And this expert endoscopy evaluated the margins of the lesions and also the structure of the lesion. And we can see that it is well pelliculated, which, as Bogdan said, is a very nice feature for any kind of en bloc surgery. It's a very nice case, and doing it using the laser because of the location, because of the pellicle, because of the absence of satellite lesions it's a good indication. It's very well, it's a very good decision. Then, and you're right to point out this limitation, this unmet need, is how do we get rid of the lesion when we have resected it? And that's super complicated because 3 centimeters that can be complicated. And by the way, cannot be done using this kind of instruments. So you will have to open the box of a resectoscope for that. So that's why quite often I say that the laser is nice, but the resectoscope is versatile and can do not only the resection itself, but also the fragmentation and also the extraction to some extent. Some people try to use the bags. I don't know, Bogdan, do you have any experience with the endo bag for this kind of the surgery, which might be one way to do it?
There's one thing that I asked Norberto if he has an endo bag available before this session.
Yeah, Bogdan, I do have the
last
bag.
week we talked about
However,
it, and I mentioned
in this case, even if I
endo
have
bag
the
is a good
bag,
solution.
I
That's my
have to
point.
fragment
If you have it, it's good to use it. Roberto?
Yes. Yes, yes.
Do you have experience
Who is
with
asking?
the endo bag for tumor bulk extraction? Very good question from
Yes,
Professor Malavaud.
I do have the bag, which usually our colleagues, the gastroenterologists, it's impossible to do it without cutting, because even if I have the bag, I cannot remove it in a male 3 centimeter tumor through the urethra.
And how do you plan to extract it now?
Tell me. I need to, before, I need to coagulate the circumferential part of the base of the tumor without breathing at all. The first step is the demarcation around the tumor, leaving at least 5 millimeters of
Norberto?
healthy mucosa. Yes, Giorgio?
Yeah, what you are doing, yes, I feel it is really, really important. So the margin to have a very clear, nice, and bloodless procedure. Because one big advantage of Bloc with laser is show what the pathologist has in its hand. But the other great advantage is about the clearness and the bloodless procedure we are doing. Think about doing the same procedure with the conventional ERBT. It's a mess. You will see bleeding and bleeding all the time. You have to pass a lot of time vessel bleeding. And with this kind of procedure, sure, you were struggling a little bit to take the piece out, but actually you are clear, nice, and bloodless.
If I may reinforce this very important comment, whatever the energy that you're using, laser, heat, actually, or plasma kinetic, bipolar, or monopolar, en bloc surgery can be expertly performed only in a bloodless field. And therefore, we have to re-evaluate the strategy that we apply. And this is exactly what you're doing now. You are first defining the margins around the lesion, and then doing some preemptive coagulations of the major feeding vessels. Then, and only then, you will do exactly what you're doing at the moment, is to decide how deep you want to get into the thickness, the bladder wall, the thickness of the bladder wall. There, obviously, you have decided to go at the right plane, actually, not too superficial, not too deep, and to cut some smooth muscle bundles that we have seen not here, but 10 to 20 seconds before. And this slowly will, by the contraction, the shear contractions of the bundles, will actually widen the scar, the incision that you have made, and facilitate the dissection. Dissection that is done, as you are very nicely demonstrating, by section, by blunt dissection. And in that matter, the fact that you have a bulky tumor is very helpful, because you can use the tip of the resectoscope to push away the lesion to develop the planes. And you also have some sort of hydrodissection because there's very little scarring with this technique and also with other techniques like plasma kinetic resection. And therefore, the saline that you're using slowly actually facilitate the plane, finding the plane and following the plane of dissection. But it's a very nice demonstration. I don't have any doubt, and we don't have any doubt that you will successfully complete the en bloc resection of this lesion. But still, how do you manage the specimen when you
Mejorar el
have done
rendimiento de la
that?
coagulación. Cuando yo uso común 1 y 10, coagulo mucho mejor.
Norberto,
Yes.
this is Felipe.
Hey, Felipe, how are you?
I like to do my en bloc resections with the same laser, and I try different settings, and I believe
Okay,
that
please.
with more frequency and less energy, I use 0.6 and 30. I have a more linear cut, not so paused. Have you ever tried different
Yeah, the
settings?
idea is not cutting at all at the beginning. I want to coagulate before, and then I agree, increasing the frequency would be the way to go, but initially I have to demarcate and coagulate all the circumference area, but I'm not totally satisfied with the hemostasia. Okay.
But maybe
better
it
now.
will improve the hemostasis with this higher frequency too.
Okay. See?
Norberto, another comment that I would like to make. I highly appreciate the quality of the dissection of the bladder wall with the fiber laser. No doubt, it is nice and clear and accurate, and that is something that you don't get to see that well with the bipolar enucleation that I use, for example. I use, as Professor Malavaud mentioned before, the plasma kinetic, actually the plasma button from Olympus, but that's just a detail. So the hemispherical shape electrode to dissect the tumor base. So on one hand, I'll give you that it's not such an accurate dissection of the anatomy of the bladder wall and of the tumor base. But on the other hand, I have
maybe
to
you will
say
see-
that I rarely see bleeding sources left behind by the button. So when you use the button, even in vaporization mode, it does a lot of coagulation and really closes down the large caliber vessels that are vascularizing, especially a tumor bulk as big as 3 centimeters. So the point I'm trying to make is that every technique has its advantages. I totally agree. I think they're both excellent choices. But in terms of hemostasis, actually, I always had a little bit of doubt, also during BPH enucleation with the laser. A little bit of doubt about the capacity of the laser, of the capacity of coagulating large.
And you will see the coagulation at any vessels in a few more steps. We will see the basement of the tumor, and we for sure need coagulation.
Beto,
So shall we summarize the main points that you've demonstrated so far? And I will ask Professor Gaevlete and Thomas Herman was around here. How do you stratify your by time your objectives when you are embarking in this kind of surgery? First, delineate. First, understand. second delineate, then.
So I start the tumor-based dissection, of course, after delineation retrogradely. So from the bladder neck, let's say, from the more proximal towards the distal, so that I push back the tumor bulk and it doesn't fall over the resector scope and the active element. And then I detach it. I also use a little bit of mechanical detachment with the bipolar resector scope, which I think is an advantage because I see very clearly the layers of the bladder wall. I love to do that. And of course, I use coagulation only when there are large videos because it is my experience that bipolar energy provides you this advantage of concomitant vaporization and hemostasis. So I get a pretty good, pretty clear view without too many bleeding sources. And then, of course, I gradually detach towards the posterior side of the tumor until it's completely separated from the bladder wall. So that would be these would be the steps that I follow. And of course, I like to do a biopsy resection of the tumor base, just to verify that. Well, I got used to it. Now probably it's not that necessary because I get the trusor in the specimen most of the times. I mean, it's just as good as ERBT, the standard ERBT. But I still have this habit of taking a few chips from the tumor bed area with the loop, with the bipolar resection loop, just to certify the complete tumor ablation on one hand and the tumor staging on the other.
Okay.
I don't know, perhaps it's a little bit too much, but this is how I do it.
No, it's certainly not a minor question, a minor objective, knowing whether the resection has been complete and extensive or left some lesion behind. This is the basis of the second ERBT in T1 high-grade lesion and so on. The discussion on second ERBT. There are many different ways to assess the extent of the quality of the resection. And actually, those ways and those questions can be addressed only on Bloc specimens. One of those was to actually ink the deepest part of the resection and to pin it on a board. Are you using this system? I like it very much, but I'm quite open to discussion.
Well, I get this point, and I do feel if you can perform a very nice en bloc resection with a deep catch of the muscle, it's pointless that you do also a cut with the normal loop to get a deeper resection to know how the muscle is going to be. But if you have this kind of case we are seeing, that could be tricky, that sometimes you cannot be so deep as you want, the exit strategy is surely to make a deep catch to have the impression on the muscle. That was a must when you were doing a ERBT resection, I mean a conventional one. If you are doing an en bloc, your aim is to have everything, I mean muscle, connective, epithelial, and the tumor in just one specimen. If you cannot, the exit strategy is surely to have a deeper catch of the muscle.
That is an excellent comment. And again, it brings us back to the controversy and actually the actual benefit of RET-ERBT in high-grade T1 lesions, just to assess the completeness of the resection. Here we say that to some extent, because of the quality of the dissection that we get with the en bloc, we can actually get either a catch of the deepest layer of resection as suggested Bogdan. You say that this is usually not useful, but in some specific cases it can be of help. And I'm suggesting that actually inking the lesions and putting it on the board give me at a second time the information that you were looking by rebiopsy. So it's still a hot topic, and I'm quite sure that the development of the en bloc surgery will play a tremendous part in setting up and settling this question. One point is also that when you're doing en bloc like that, either using laser or whichever form of energy, actually you see very nicely the structure of the tissues. And as we can see here on Alberto's procedures, we can see the bundles, we can see the space between the bundles, we can see the epithelium. And when we have a muscle invasive lesion, that the fact that we have a very nice bloodless field allows us to get some very good insight on whether it is a muscle invasive or not a muscle invasive lesion. What's your opinion on that? Do you have any tips and tricks that you might want to share about determining whether there's a high suspicion of muscle invasiveness?
Well, I think, of course, it depends on experience, because you get to notice the aspect of the tissue macroscopically. Also, I believe that, for example, the fact that you produce less char, less burning of the tissue is a tremendous ability to make the difference that you pointed out very nicely. So I think that from this perspective, both the laser and the bipolar plasma provide you this disadvantage, and I think that is important. Of course, the last word belongs to God, which is the pathologist, and he will decide what is invasive and what is not invasive. But of course, it's good to realize during the procedure, if there's a very profound tumor that goes beyond the trousseau, you have to realize when to stop in order not to produce a huge perforation in the bladder wall and to go outside the bladder. That's important, of course. But in the end, as you all know, the last word belongs and staging belongs to the pathologist. But then again, I think we have good quality energy sources, both the laser and the bipolar, that keep up the level of good vision and good individualization of the structures, both in terms, especially if you have no bleeding. And this is why I find it very important to have a nice hemostasis. I've seen Norberto working a lot on that, and I still believe a little bit that perhaps the laser facing large vessels might have a little bit of a disadvantage.
Shall I push a bit further the discussion? You said, okay, I don't want to perforate the bladder. Okay, that can be discussed. I want to offer a complete resection to small T2 lesions in old and frail patients in whom I want to preserve the bladder because they are not fit for radical cystectomy. So there is still, even in the EAU guidelines, some room for bladder conservation in small T2 lesions. And the fact here that before embarking into getting to the theater, we got an MRI, we got a very nice and thorough preoperative evaluation is, to my mind, a very important and very modern aspect of managing non-muscle, but also small muscle invasive bladder cancers. If you look at the EU guidelines, it is said that if you have a single lesion that can be microscopically fully resected with no CIS and no upper tract dilation, it is an indication not only to radical cystectomy, but also to bladder conservation based on the famous trimodal approach. And that's why I believe that we are all keen on developing the en bloc surgery, because we love this surgery, there's no doubt about that. And I think the next step in this en bloc surgery is to see whether it can be applied to some very tricky situations. I've presented some cases of en bloc of lesions within the diverticulum. We also have all had some experience on small T2 lesions that we completely resected and then were subjected to trimodal treatment. So the story is not finished. It's still developing and very rapidly. And still in this development, we still have a big block of trouble. And this is getting out the sample when the samples are large. And this is, at the moment, for me at least, and I believe to my colleagues, the most bothersome aspect of this surgery. Sometimes you spend 20 minutes, 30 minutes doing a very nice en bloc of bulky tumors, and you spend 1 hour to get it out because it's pain. It's not easy. So there are many tricks there, and possibly we might, you might want to share your tricks and your suggestions on how can we get out large lesions, such as this one, for instance, without using the bag, because the bag is a different question. It's not yet widely diffused and not widely available, but there are still some other tips and tricks to manage these situations. Both Giorgio and Bogdan, possibly you might want to share your tremendous experience with us.
Well, one obvious choice is to cut it in two. That's a possibility. Another choice would be to use larger grasping forceps. Occasionally, you need to take it out with the resectoscope altogether, because the tumor doesn't fit the axis sheet of the resectoscope, and sometimes you need to take it out entirely. And at that point, I'm very worried about the tumor sitting in the urethra. I'm very worried about that. I try to avoid it. I don't like it. I don't think it's the best way to go oncologically. Other than these two, and the endo bag, I don't have any magical solutions. I completely agree with Professor Malavaud on all accounts. Of course, for special cases of PT2 without an indication for cystectomy, a deep resection is the way to go, because it is the only way to go. And I fully agree with it. And on the other hand, this is why I kept mentioning the question of the size, because it's frustrating. It's frustrating. It's like you are making love to a beautiful woman, and afterwards you fell in the shower and break your head. So that's my feeling. My feeling with the large tumor bulk being extracted. These are my tips and tricks. I perhaps we can find out more from Giorgio, maybe.
I'm not a magician too, and I can just underline all the tricks already said. The only thing that can change a little bit, but just a little bit, is shifting, like the enucleation, to the morcellation process. So you need at least to save the bed of resection, so the lower part, so you gave to the pathology something that is actually useful to have an impression about the connective and the muscle. And you can go outside with all the floating part with the morcellation. For sure, you just are losing the benefit of the en bloc, but if you are really precise to cut it in two, and one of the two is the base of our tumor, the part that you morcellate can be done. But it's something that I've done 2 times in my life with very, very big tumor. And at the end of the day, I was not sure to have given the pathology the correct chips. I was lucky, like any time of my life, because I always tell to my wife that better to have a very skilled surgeon in the theater is better to have a very lucky surgeon in the theater. But given that, morcellation is it's not plan B, plan C, it could be the plan Z, I think. But it's the only one that I can add in the list that was already done.
Professor Bozzini,
May I tell you a personal story? When I was a resident, meaning quite a long time ago, my professor did the surgery. I was amazed. I said, "Oh, sir, we have been very lucky." And he told me, "Young man, please remember that only talented surgeons are lucky." So possibly, Giorgio, you're a talented surgeon more than a lucky one. And this is a personal story. Please share it with your friends and your wife. So that's the first point. The second point is I like very much the idea that when the lesion is bulky, we have to split it in many pieces, at least 2 pieces. And then I have the feeling that this decision has to be taken before the specimen is fully loose, fully detached from the bladder wall. Otherwise, it's floating in the bladder, and to do a resection of something that is floating in the bladder is a nightmare, and this is very dangerous. So if I'd like to know whether you share the same opinion, that is that when we want to split the tumor, and then we discuss the technique to split it into many pieces. When you want to do that, it has to be decided before severing the tumor from the bladder wall, and it has to be, and therefore, we must avoid at all costs having a bulky tumors floating into the bladder and having to resect it into pieces. Shall we agree on that?
I fully agree on that. It's the same as with the BPH enucleation. If you do a nuclear resection, for example, and you don't use a morcellator, or you don't have experience with a morcellator, and you plan to extract the pieces, then you should not detach the lobes, because if they float around in the bladder, it will be a technical nightmare. Same as with the tumor. For this reason, another reason, we try to avoid tumor seeding. We try to avoid tumor spreading of the cells. We should not do more than during a ERBT. So yes, the planning is very important. Yes, cut it from the very beginning before you detach it from the tumor base, because first of all, it will be technically easier. Second of all, it will be faster. And third of all, you will spread less tumor cells in the bladder.
May I add some comments from the audience?
Professor?
You hear here the deepest part of the in-block resection is a small perforation. I didn't feel it at all. Most of the tumor is free, but still have a small piece ligating, linking to the tumor. The target, the goal was reducing the irrigation of the exophytic mass and control the bed of the in-block resection regarding the hemostasia. But the following step is just to cut it, but it's not easy. Let me try it. Let me coagulate a little.
Norberto?
Yeah.
It's Felipe from the audience.
Yeah,
I
Felipe.
would just like to contribute to the discussion about the extraction. We have a recent paper from Dmitry in Kiev showing that the morcellation of huge tumors like this is a really nice option. And even if you morcellate everything, you give good specimen for the pathologists. They can find muscular cells and they can see if the muscular cells are invaded or not.
But the idea is sending the basement entire without morcellating.
Yeah, and another option that is more challenging, but I think you can try in this case, is now that you have detached 99% of the tumor, you can use the morcellator to remove the upper part of the tumor, and then you leave only the base to be extracted en bloc, because the pathologists, they only need the base of the tumor
That's true. That's what I need. The base that I
Yeah,
need.
yeah. So instead of cutting with the laser or energy source, you just take the nephroscope, and now the morcellation is bloodless because you did an excellent job in a huge tumor, and it's a very challenging case for life surgery. I would like to congratulate you, and it's a nice option. It will be much faster with the Storz morcellator to remove the upper part, and then with a 5 or 10 millimeter base, you extract and block.
Let me see if I can complete the dividing in twice.
I'd like to ask my
into
fellow
pieces.
moderators, what do they think, intuitively, of course, that the morcellation process will do in terms of tumor cells spreading and tumor cells? How many tumor cells will we, and how much, what quantity of such tumor cells are we going to spread around in the bladder? Is it going to be perhaps more than during a
But I need to divide in two pieces just to
resection?
Well, if I can give my opinion on that, it could be the seeding similar or inferior. Similar because when we get back pieces from a normal ERBT, we are just washing with the pump or an Helix pump, and this is what happened. If we are using the morcellator, actually we are aspirating, we are making suction. So, rationally, all the seeding cell have been aspirated because I have a suction that aspirate the tumor and morcellate it, and also we are aspirating the cell. But it's something that is just what I'm thinking about. I'm not doing actually a study on it. It's a nice idea. I will take a look of an EKF work, which is always a great mind, and I will look into this paper. Because in my opinion, at the very first time, I was thinking that seeding could be a problem, but given the fact that you, during your morcellation, you are also aspirating, all the cells and all the liquid has been aspirated by the morcellator.
I believe Thomas Hermers is online. I would like to hear the opinion of Thomas about morcellation.
Thank you very much for getting me into the discussion. So I'm just moderating the next session. So I just wanted to give one brief comment. I like the paper of NEKF, and I like the idea of morcellating because that would turn over the problem of large specimen retrieval. However, we need to consider that this is not yet, let's say, backed up by a consensus between pathologists, uro-oncologists, and us. I think it is clearly visible that this works out. And I think from the theory point, it's true that we just need the base. However, the question is if we don't lack information by morcellating the exophytic part. That is basically what we cannot tell if we morcellate that. With regard to tumor cell spillage, I think en bloc resection has a charm that you virtually don't need any irrigation afterwards because it's basically bloodless. And at least I would advocate to do the irrigation post-operatively. This has been shown to be almost equally effective to early installation of MMC. That's what I would do to be on the safe side. But however, we need to counsel our patients if we do something like that, that this is not yet backed up by literature. So literature, of course, but not by guidelines as a, let's say, standard procedure. But I'm 100% sure that this will come.
This is the pulsation of the artery below.
Scary.
Yeah.
Okay, let's remove the fiber, and I will remove I put a nephroscope, and I remove with the basket.
Beto,
Yeah.
in the case, like many of us that have a low power laser, which kind of setting would you prefer?
1 joule, 10 hertz.
That's it.
No. They are asking if I have a low power laser, what can I do, and the setting.
Take bipolar.
I think we are all in agreement on that. Use bipolar.
But Thomas, I have
Thank
to be
you,
very
Hans.
clear. I have the bipolar on the table because it is
Thank you, Thomas.
always.
You made my day.
So possibly we might want to discuss further the issue of seeding cells in the bladder. We know that the concept has some value because, as Thomas just said, irrigation, postoperative irrigation of postoperative early installation of mitomycin C do reduce the odds of recurrence, mainly in low-grade, low-stage cancers, not too much in high-grade cancers, but still it has value. So the fact is that there's something to be done. Whether it can be done by using the morcellator or not, I don't know. And actually, I don't know. One thing I'm certain is that when you look at the differences of locations between primary resections and recurrences, the recurrences are almost always found at the top of the bladder, never at the trigon. So it is, to my mind, essential to pay attention to the floating debris that we have collecting at the dome and close to the bubble at the end of the surgery. As I tend to say every day, I'm getting old and I'm repeating myself, at the end of the dinner, the table must be clean. So when we have completed the resection, we have to take out everything, not only the specimen, but also all the floating debris. And if we have to spend 5 minutes to do so, let's take 5 minutes. That's important. To my mind, it's important. And then either you have to decide either postoperative installations or close to 24 hours of saline irrigation. Effect is the same, but effect is beneficial in both cases. So that's the first point. This is the point of seeding, but this is not the only benefit of en bloc resection. En bloc resection has 3 main benefits, and I'd like my colleagues to either support or comment. The first benefit might be seeding. Okay, might be, no proof. The second one is the quality of the specimen. There is no doubt. And whatever the technique, whatever the energy, the specimen is better, and the specimen is more adequately analyzed by the pathologist. Third, is this the safety of the procedure? Because it is safe. It's much safer than doing a piecemeal resection, because we follow a plane of dissection, because we do that in a bloodless field, surgical field. So these are the 3 main reasons, to my mind, why we should develop en bloc. And if at the end of the day, because the tumor is too bulky, we have to fragment it to get it out, so be it. Possibly we might lose a bit on the seeding aspect, possibly on the pathological aspect, but we still have the benefit of safety. What is your opinions? What's your opinion?
You're absolutely right. You're absolutely right with all 3 points. And I would just add one. So we did in Word Journal, we did a anniversary collection last year about, because the Renaissance was about 12 years ago. And I think one further point I would like to mention is you don't miss lamina muscularis propria invasion. You not only have a better specimen, but you don't miss lamina propria invasion. You can do substaging, And that is very crucial. If we remind, so not all people around the world have access to recurrent re-TURB in a certain time frame. And if we consider this, then this is the absolute, I think that is the most striking point, that you don't miss lamina muscularis propria, which for me is the point of decision to make on how the treatment of the patient will go further on. Or if you say, for me, it's T1 substaging that is the differentiator on where I want to guide my patients. I think that is really, as you said, the specimen is much better and you don't miss lamina propria. Because we have studies around who show that if you have on block resection free lamina muscularis propria, you don't find it in the re-resection. So you will find it, of course, in re-TURB in about 30% of the cases that were T1, and that is something you will not see once you do ERBT.
I fully agree with the points that both Bernard and Thomas made. They're extremely correct. I made the presentation, a state-of-the-art presentation last year that said unblocked resection perhaps better for the pathologist than for the urologist, specifying that the great part of the literature underlines what a big advantage is in terms of accurate staging, exactly in connection with what Thomas was mentioning about the muscularis propria, about not leaving any filtrative lesion behind. And I think this can be called progress. On the other hand, regarding what Professor Malavaud was saying about being safer, intuitively, I agree with him completely. Unfortunately, I have a little bit trouble proving it, because the problem appears when you gather statistical data and you search for statistical significance. And we had the Delphi consensus, 3 rounds of it, which is all, perhaps not all, but many centers, most of the centers that are doing unblocked resection. And at the end of the day, the difference was not exactly statistically significant in terms of bleeding and perforation and so on. Although it is also my opinion that obturative nerve reflex is more rare, that the perforation is more rare, that the bleeding is more scarce, and so on. So we still have some effort to do about gathering data. And there's a nice registry being developed now by Jeremy Teok from Hong Kong, which also gathers a lot of clinical departments with experience in this field. And I feel very confident that gathering hundreds and hundreds of patients from several centers might have an impact on the actual statistical significance of data and clinical progress. While in terms of seeing, last point I wanted to make, and the first point Professor Malavaud made earlier about the tumor seeding, indeed it is difficult to quantify, and we have been struggling for years to improve the recurrence rate, and data shows that we haven't changed much, and there's still more work to be done, like Barack Obama would say. So in terms of ecological impact for recurrence, I'm not sure we have all the answers, although intuitively I believe in unblocked resection as a more accurate oncological technique.
La fibra. Dame la fibra.
So if we try to sum it up, we are all concurring on the fact that we have better specimen. The specimen is easier to analyze, and actually the results are more accurate. Therefore, we might understand that the staging of the patient and the risk stratification of the patient is improved by this technique, but we have no proof that this better risk stratification does ultimately translate into better either recurrence-free survival, and although survival is another story. I'm fine with that. I might still argue that we don't see any differences in the secondary effects. Nice specimen, by the way, Alberto. No, we all agree that we might not have the proof that it is safer to do it en bloc that in the classical piecemeal way. But what we can also conclude is that the surgery that we are doing is better. So it might not be safer, but in terms of quality, it's better. So if you are looking for quality, it is safer to do it with the en bloc than doing with the piecemeal resection, which is not very safe. I always find myself a bit in trouble when I have to, for instance, to reduce the volume of the tumor and to do a standard resection before doing the en bloc of the foot of the lesion. It's always a bit bleeding and not easy to manage, but that's my personal opinion.
We had the Urotech meeting this year in Vienna, and I said, en bloc resection will make no exemption that anatomical surgery will produce better results. That's it. It's anatomy, and anatomy always wins. This is true in enucleation, this is true in ERBT and robotic surgery. It's always anatomy. And in addition to what you said, and with regard to the safety, the study in Puigverd showed, because it was predominantly residents, that you can nicely teach it to residents much better than piecemeal resection. So they are improving their results in the early phase of their learning curve so dramatical that you can expose them to this surgery without losing information and putting the patient at risk.
And one last.
You're right. The training is.
One last feature now favoring the laser is in lateral tumors like this one. With laser, we don't have obturator reflex. This is a posterior lateral tumor, but in a totally lateral tumor, if we have the laser, we don't have the obturator effect. That can happen with monopolar and even with bipolar, and then induce a perforation. I know you are all fans of bipolar energy, but I'm defending the laser here.
The obturator nerve.
I'm totally fan of lasers, and you're absolutely right. But if you don't have an appropriate laser at hand, then the next thing you should have is bipolar. That's it.
Beto?
What I would advocate is with a bipolar, you can do whatever you want in whichever position within the bladder. With a laser, I have some doubt about it. But still, if you have the laser, you're right, there is no transfer of electricity and therefore no stimulation. And you're right that in lateral wall tumors, it's definitely a worry that you can kick off, get out.
And it looks so nice. So what we see from the excellent surgery is that you have a real nice area where the specimen was harvested. You normally don't see this in TURBT. So this looks already better than TURBT.
Oh, sure,
Congrats to the nice surgery.
Sure.
Beto?
Do you have a camera to show the
I
tumor?
agree as well. And also with the advantage of obturator nerve reflex, which is diminished in bipolar, but not inexistent. That's true.
This image, that is not the best one.
Really impressive.
The sample is okay, Beto?
¿Cómo?
The sample.
¿Lo vieron? Did you see the sample?
Just a little.
Could you show it again? Pueden, no sé si están mostrando porque yo estoy de espalda.
No, tenemos la visión endoscópica. Ahora.
this is a time where I would advocate inking, putting some Indian ink on the deeper layer of the resection and pinning it on the board. Why? Because it gives the pathologist a very strong information about how deep you've been dissecting, and second, because it avoids any contraction of the smooth muscle bundles, which actually transform something that usually is quite flat into a big ball that is not that easy to analyze under the microscope. I'm quite keen on pinning and
Bernard,
inking the mark.
what kind of endoscope are you using for the bipolar, Bernard?
The Olympus one, 27 French.
Olympus one. Okay.
Classical. You know, the Swiss pocket knife. With that, you can do whatever you want, including silly things.
And which is the drug that you are using when
Me too,
you
also the
finish?
Olympus, but for the action with the bipolar plasma electrode.
Which is the preference of the panelists regarding the irrigation when you finish the surgery? Mitomycin, gemcitabine, anyone, just irrigation with physiologic?
That's simple. In Romania, you find more seldomly gemcitabine, so we use what we have. On the other hand, gemcitabine is less expensive, if I'm not mistaken, and in the third place in life, as in surgery, you have to be happy with what you have. So we use mostly gemcitabine.
Okay.
Actually, your question shows that we are all aware of the benefit of doing something else at the end of the surgery. And this was discussed while you were doing this fantastic surgery, and we said that either saline for 12 to 24 hours or postoperative instillation. This is in the guidelines, but we know that it is not very effective in high-grade cancers. Shall I? Do we all agree on that?
Absolutely.
Absolutely.
But it has to be done. So never do a primary resection without something after. Whatever you like. It can be gemcitabine, adriamycin, epiribicin, mitomycin C. Actually, they are all effective. All.
Professor Mohammed Omar is also there on the panel. I would like to ask what he's doing in Egypt after TURBT.
Hi, how are you? Thanks for letting me have this nice meeting. And usually we just have irrigation for 6 hours. And then after 6 hours, if it is a clear, crystal clear, maybe we have a single route of injection of doxymycin. So this is our regular regime. Sometimes I may be earlier than this. If I'm using bipolar, usually it doesn't have any fear with hematuria. Usually after bipolar, I have a clear bladder without any hematuria. So I'm sure if I don't have any perforation, I ensure that my resident is going to inject the doxycycline. This is our regimen in every case, either immediately or after 6 hours, but we prefer like after 6 hours. So we don't have mitomycin. So we have a shortage in Egypt for mitomycin. So this is why we're using doxycycline or pharmaopsin or something like this.
Thank you.
So I have a small comment about doing Bloc and using laser and bipolar. So my question is, would you prefer doing the same surgery with thulium fiber laser, or do you think that holmium is the best, or the thulium YAG even? Between these three lasers, if you have to choose between one of them, which one would you prefer?
Thulium YAG pulsed.
Okay.
That is, for my opinion, at the moment, TFL is nice, holmium YAG pulse modulation is nice, but thulium YAG pulse, we have two companies that providing that is for me at the moment. We have all three, and I tend to use at the moment for that with regard thulium YAG pulse is the most versatile. So what I expect.
I was asking this question because I did a trial. I was comparing between the three machines, holmium, thorium, and bipolar. I cannot say one is bad and one is good. I will keep this for the trial, but I would say I'm taking too much time with any laser. If I'm doing the same with the bipolar, and it's not resection, I use a needle, what we call the coolant knife, to doing in block. Like if I'm doing the in block in 15 minutes, I will be doing the in block with the needle in 2 to 3 minutes. I know that the power of the bipolar is a little bit deeper, and in the sample, the charring effect with the bipolar little bit deeper. Yes, I would say there will be a difference between 1 millimeter in laser and 4 millimeter at least in bipolar. But I'm talking about 3 minutes surgery with the same time of the tumor versus 15 to 20 or more if it is having a bleeding like this case. So maybe we have to decide, like, if it is taking a lot of time, maybe bipolar, maybe or thorium would be better than holmium in the bladder. Like prostate, holmium is doing well. We could keep it for the prostate, but for the bladder and the ureter, maybe thorium is a solution besides the bipolar.
I would say you use what suits you best. There is no clear answer to that because not all energy sources suit one well. So I think you have you select your favorite tool, and there's nothing wrong about it. That's always what I would say.
Adding some more spice in the discussion, with the laser, you can do the 22 French en bloc resection, and with the morcellator, in the Morse scope, you can morcellate the upper part and remove the base through the 22 French sheath. So the Swiss Army knife is 27 French. And with any kind of laser, holmium, thulium fiber, and thulium post, you can do everything without retrotrauma. And bladder tumors are recurrent disease. This patient may need a second, maybe a third TURP in his lifetime. And it's better to be in the safe side concerning the urethra.
Yes, but there is 22 French bipolar now.
Yes. And then there's one Swiss Army knife, and then you have a whole regiment of instruments. Oscillator, laser, you may have to use a bag. For that, you need a nephroscope. Well, okay. Swiss Army knife does everything. Not always it requires training and it requires dedication, but it does everything. And actually, it's available everywhere too. While not all centers have 3 different kinds of laser, plus a morcellator, plus an underbag, plus a nephroscope, it's a lot in terms of equipment.
Okay. Okay.
Norberto, estamos en horario para ir pasando a la siguiente cirugía. La verdad que una excelente demostración. Queríamos darte un aplauso desde el salón.
I'm not so happy. Because
Very nice surgery. Very nice surgery, Norberto.
Very
Thank
nice.
you so much for the moderator.
Congratulations, Norberto. You've done a wonderful job. And personally, I love the laser more than I did 1 hour ago. So I think you've succeeded. You've convinced me.
Muy bien,
What is the question?
muchas gracias a los moderadores y